Greetings to all whosoever is watching this live inbox case. Welcome to NH Ahmedabad. I am Dr. Manik Chopra. I am an interventional cardiologist and I subspecialize in structural heart disease interventions. Today we are going to do a TAVI case, and with me is my senior colleague Dr. Sumit Dheer, who is going to participate in the procedure. I have Dr. Gunjan Shah for echocardiography for us, and then we have cardiac anesthetist Dr. Hetal Shah, who is going to help us for conscious sedation. There is a technician with him, Dheeraj Kumar. And we have a fantastic team of nurses and technicians. We have Hemant, our senior technician, Moin, and then we have Yash. We have Jessica, and we have Altaf, who's going to scrub with me for the procedure. So we switch to the procedural strategy now.
Thanks, Manik. Good morning, everybody. We'll just give you a short insight about the strategy which we are going to follow for today's case. Now, we'll be putting in a 7 French sheath in the left femoral artery for a 6 French fictile catheter and for blood pressure monitoring. There will be 8 French sheath in the left femoral vein for the temporary pacemaker wire and an extension line for drugs to be given. We'll be using a 14 French Python sheath in the right femoral artery. One ProGlide will be there placed in the right femoral artery. Safari extra small wire for the THV deployment. A balloon tipped TPI wire for pacing at the time of deployment. An 18 millimeter mammoth balloon will be used for pre-dilatation of the valve. A 21 millimeter my valve THV is planned at a nominal volume -1 cc to be deployed in the 3 cusp in the RLCO view. Assessment of the procedure will be done by the angiogram and hemodynamics and a 2D echo simultaneously. Vascular closure will be done at the end of the procedure with one ProGlide and an 18 French angio-seal. In case there is some vascular problem or a complication, we have everything ready for a vascular bailout with a 7 millimeter PTA balloon, an 18 millimeter non-covered and a covered self-expanding peripheral stent if there's a necessity. Thank you.
Yeah, that's correct. The only thing is it's 21.5 myval. We are taking something minus, so we are anticipating the diameters to be 21. Let's take a 12 French, which is already there on the table. Just put a 12 French. So it's a hydrophilic sheath, and initially we had kept the Merrill loco down because the tip of the sheath is slightly differently designed, and once you cross the puncture point, you would rotate it to bring it on the top. So the Merrill now is on the top. Now we want to see the aortic arc straight away. Till this point we go in. You can see there is a sleeve there. Go in. That's it. Okay. Let's give full dose heparin now. So at least let's give 9,000. 2,000 plus 7,000. So there are 2 ports to suture. You can see there is one port on the left hand side, the other on the right hand side. We make sure that you take a bite enough proximally to the port so that even if the sheet moves, it moves in rather than coming out during the exchanges of the balloon and the THV. Pace at 120, output 2. Stop pacing. This is good. Suture, please. Show the aortic arc and show the, yeah, good. Show the ascending aorta, that's good, yeah. We'll try to push this into the right cusp if possible. Can you come to the first angle, please? Inject. Yeah, so we see we have right coronary artery and the left coronary artery clearly seen, and there is a lot of AI also, as we understand, and the catheter is in the right cusp, so we can opacify everything. So here we are. We have a 7 French sheath which is lying in the artery, and we have a pigtail catheter here which goes through it, and the port is attached to the continuous pressure monitoring which shows the pressure on the screen. We have a temporary pacemaker which is balloon tipped from the 8 French venous sheath, which is already there, and then we have an extension line for the anesthesia to give drugs. We have a 14 French Python sheath with one ProGlide which is already done, and at this is what we have done till now. So with this, now I'm going to push the pigtail catheter into the non-coronary cusp, because that is going to help us in knowing what is the lowest portion of the coplanar view. Alright, so now we are going to cross the valve. Our standard is AL1 catheter with a Teflon wire, a straight tip Teflon wire. We can see the calcium in the aortic non-coronary cusp, and the wire is already in. See, this is the wire, as I believe. Come to the RAO caudal view, please. Give a RAO 30 degree, please. Okay. So next we are going to push a axial length J-tip wire into the LV so that we can place a pigtail catheter and we can place a safari wire more safely. So this is axial length wire which goes in, and it's lying at the apex as I understand. So we are going to take this AL1 catheter out slowly. There are some VPCs, but they are related to the wire. So now the pigtail catheter goes in, and we are going to take the axial length wire out once the pigtail is parked at the LV apex. Next, we are going to do hemodynamic monitoring. So we are going to connect another pressure line to the LV pressures, and very soon we are going to see both the pressures on the screen. So you can see that there is a huge gradient in between the LV and aorta. Uh, really high gradient, severely stenosed bicuspid aortic valve. Gradient more than 65 to 70, I believe. Let's save this. Okay. Okay. So before we put a safari wire in, we want to make sure that the valve is ready to use, because sometimes safari wire itself causes a lot of aortic regurgitation, and then we need to rush on. So it's best that you check the valve first. So you can see that the skirt is down, and this is a 21.5 intermediate size valve. Again, it's an advantage than the conventional sizes, because this patient has an annulus of around 20, and it's best to get a 21.5 for him, for her. 20 would be too small and 23 would be too large. So this is how the system looks like. This is the shaft. Let me show you like this. There is this handle in which you have possibility to flex this so that it crosses the aortic arc, and this is the inflation system for this device. So now we are going to put a safari wire in. It's a pre-shaped wire which goes from the pigtail catheter, and it goes in, and very soon I'm going to push it into the LV, and it's already at the LV apex, which is at a good position. So now I'm going to slowly take my pigtail catheter out, and now we are ready to do a pre-dilatation also. Flores. Next, we are just going to prepare the sheath with a 18 French dilator so that you know the valve as well as retrieval of the valve becomes easy for us. It is sort of a preparatory move. So once this goes in, you can hold it with a dry gauze and go in. Of course, these are large femorals, so that should not be a problem. In small femorals, it might be slightly painful to the patient sometimes. So I pushed the dilator all the way in. Let's hold it. Now I'm going to take it out again. So this is a mammoth balloon. This is a 18 millimeter mammoth balloon which we are going to use for pre-dilatation. Stepping. Yeah. Leave the wire. Slowly, slowly. Good. So now we are going to push the 18 millimeter balloon across the aortic annulus. So you can go in, sir. Okay, this is a good placement. You can see that the middle marker is exactly at the level of the pigtail. So lower border of the pigtail. Okay. All right, fluoro is on. Pacing on, please. Pacing off, please. So we can see some degree of QRS prolongation just with balloon dilatation. So maybe the patient has some inherent disease also. Now we are going to deploy the valve. We are going to mount this valve on this safari wire, and you can see that there is an introducer over the THV, and this goes in. You push this introducer in, and then you push this orange part, and now the orange part only. So we have parked the THP in the descending thoracic aorta, and now we are going to flex this. You can see this is how we are going to flex. I'm going to give some flex to take for the arc. LAO 30. We want to see the aortic arc as well as the wire if possible. Yeah, that would be great. Can you pull the table towards you? Now we are going to navigate the aortic arc. I have already given flex and Dr. Sumit is going to push it in slowly. Good. Come down on inotropes if you are giving any. So it was a smooth transition, you can see enough. Alright, so we are going to push this valve inside now. So we are going to check the position now in the coplanar view. Are we ready with the contrast? Alright, let's check the position in RL cusp overlap view also. Inject contrast. Looks reasonably okay to me, I think. So we have removed the parallax from the coplanar view and now we are going to take one more aortogram. Inject. Yeah, looks pretty okay to me. I can clearly see the valve leaflets by the side of the my valve. Inject contrast, please. Go up slowly. Go up slowly. Go up all the way, all the way, all the way. 1000, 1000, 1000. Deflate. Pacing off. Fluoro safe. So we are going to check the coronary perfusion in a LAO view. Inject. Yeah, looks pretty okay. So we are going to check the depth of the valve and degree of aortic regurgitation in the RL cusp overlap view. Inject. Yeah, you can see that the valve is sitting pretty high and there is no aortic regurgitation. This is the best view in which there is no overlap with the aorta and you can see the LV completely. So now we are going to do hemodynamics. Okay, let's take this out. Next, we are going to check the hemodynamics as the pigtail catheter is already inside the LV. We have flushed both the lines and we have zeroed both the lines. So this is the hemodynamics. You can see that there is no gradient, no systolic gradient. It's a complete overlap of the aortic as well as the LV curves in the systole. And there is very good diastolic separation. The LV EDP has not increased. All in all, it looks that there is no stenosis part and there is definitely no significant aortic regurgitation. We also confirmed this on aortogram, which was taken and it didn't show any significant aortic regurgitation. Alright, so this is the echocardiogram of the patient and you can see the bioprosthetic valve. Alright, so this is the parasternal long axis view. You can remove the color, please. So a peak gradient of around 5 and probably a mean of around 2.5 or something. Pericardium, there's nothing in the pericardium and IVC is good. Okay, so this is about the echo. Now we are going to do a vascular closure for the right side and we are going to push a stiff wire into the aorta. This is our typical practice. We'll do it over a stiff wire. Next we are going to push a dilator inside. Get the 14 French dilator, please. Next we are going to take the suture out for the python sheath. We will release these threads and we are going to wet these threads so that they act nicely. And we'll again separate them, make sure that there is no entanglement in between these two threads. And I'll attach the artery forceps again to the white one. Again, I'm going to wet this thread and put a knot pusher over it. So typically you roll this like this and then catch this thread and let it slide down. Okay. So now we are going to remove the sheath slowly. I am working on the proglides. So Dr. Sumit is going to take the sheath out over the wire. You can slowly take it out. Slowly keep the wire. Now the 8 French sheath goes in. This is the 8 French sheath which is going in. There might be some vascular injury.
Flow.
Let's see. Regarding the peripheral part, there was some local dissection, so we had to put a non-covered stent at the local site, and there was a minor ooze and a small twig of the internal iliac artery also, uh, which occluded spontaneously, and we also injected some gel foam. And this is the final shoot. Let it run, please. So good flow across the stent, and there is no ooze in the internal iliac branch. Thank you. Thank you all for listening and viewing.